about menopause today. Like the invite said, a lot of us global citizens are not very familiar with menopause. A lot of us don't talk about it. It's some things you don't ask your mom about. You don't ask. You don't. It's not. We're not really open to talking about organic issues generally. So I'm going to talk about menopause today, and I'm going to go with defining menopause. Let's understand what it is, taking away the myth from menopause. Let's talk about the perimenopause period or the menopause transition period. And then we talk about premature ovarian failure because there are times that people get into menopause early as well. So that'll be something to talk about. In understanding this, after we've gone through the definition, I'll go into a bit of science. I'll break down the science to make it a bit more easy to understand. I'll talk about the causes of menopause, symptoms of menopause. We talk about HRT because I'm sure everybody wants to know a bit more about HRT. There's a lot of myth about HRT. Then we go to things like alternatives to HRT, and then we'll have questions and answers. Okay. The menopause is when the period stops flowing, and it's a retrospective diagnosis. That means that you don't know when you're menopause until you look back, and it's been 12 months of not having a period. So you need to have 12 months of not having a period. Like we all know, when especially if you have gone through the menopause, when you're about getting to menopause, there are times you have, during the transition, you can have up to 60 days of no period. You're like, oh, is menopause coming? Or you might even have up to 90 days with no period. That's not menopause. You are in menopause when it's been 12 months of not having any period at all. And this is what I've just spoken about the perimenopause. I use the example of a bulb. So we all have bulbs in our house. When the bulb is about to get to the end of its life, when it's no longer, it's going to go off, it goes off, and then it flickers, and then it turns on again. You think, is there still life in this bulb, or is there no life in this bulb? But there is life in the bulb, and that's exactly what happens around the menopause transition. There are times that we feel that we have nothing left, and we think the period has stopped, and it's about up to 6 months, and then it suddenly shows itself again. So you're not menopause until you've had 12 months of no period at all. And that is because of the ovaries. The way God has made us is giving us ovaries, and our ovaries are not not last forever. Imagine you have a basket full of eggs, and then you begin to use up your baskets in small chunks. So the time we have the most egg is when we are in our mother's womb. So when you're about 6 months old, you have about 5 to 6 million eggs at that time. By the time you're born as a child, you have about 1-2 million eggs left. And by the time you get into your period and start having your period, it's 12, it's 13, 14. Whenever we have our period, we have about 600, 700,000 left. Every month, from our basket of eggs that God has given us, we take a pile of eggs. One of them becomes the dominant eggs. I will go into the physiology later on. And that's how we take out from the bunch of eggs every month. And then when we get to a point when we have little or no eggs, at menopause, we have about 1,000 or less eggs left. That's when we've used all the eggs, and that's when we get into menopause. So it's the ovary that is gradually producing less and less estrogen because there is less and less eggs. Okay, so that's what it's all about. The average age of menopause for Caucasian is 51, and it differs for Africans depending on a lot of things. It depends on things like, if you've had children before. It depends on things like your weight. It depends on things like where you're from, for example. So in South Africa, we have an average of 48 to 49, and that's about an average for us as women globally, actually. And the range is somewhere between 45 and 55 years old. Some people actually get to have menopause earlier. So if you have menopause at younger than 40, that's called premature ovarian insufficiency, POI, or it's called premature ovarian failure, or some people call it premature menopause. We try not to use POM, the failure, because it denotes negativity. So we try to use insufficiency or premature menopause. So this is now where it gets a bit interesting. This is um, the physiology, the science behind it. So the blue, we have different bars. Some of them is telling the temperature. If you remember, I don't know the range of ages we have here. I don't know if we have younger people or older people. So I'll just talk as if I'm talking to a general, different ages. So when people are trying to get pregnant, you take your temperature and look for your basal, body temperature to see when you think your surges, because the temperature goes up a little bit. That's what the top bit is for. And then the hormonal level is the one in the second line, and that talks about your FSH, your LH, your estrogen, your progesterone. So FSH is called follicle stimulating hormone, follicular stimulating hormone, and LH is the luteinizing hormone. And I'm going to explain the basis of this because understanding HRT and understanding the menopause, we need to understand what this hormone does. So I want you to listen to me really, 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 really closely, and I hope I don't confuse you. So what happens at the beginning of the cycle? If you look at the bottom, you see the kind of picture depicting the uterus, and then the one above it is depicting like the ovarian cycle. And the way God is so clever, everything is working simultaneously at the same time to make sure that everything goes on well. Okay, so when you start your period, that's the one of your period, you bleed. Because you're not pregnant, you bleed. And once you've bled, the brain is telling the ovary, okay, we need to get another batch of eggs ready. And the way the brain does that, it releases FSH, follicular stimulating hormone. All right. What it does, it stimulates the egg sac. So your ovary, this is for your ovary. You have all the egg sacs in the ovary. You have one on the left and you have one on the right. So usually it goes alternate months. Ovulate on one this month and ovulate on the other. That's how the body does the cycle regularly. So the brain goes to sense the hormone, the GnRH, and then you get to the FSH. The FSH then goes to the ovary and say, ovary, we need to get some eggs. So get in your basket of eggs, and then it picks up the bunch of eggs for that month. The way God makes this, God's special, one of those egg sacs or oocytes, we call them, becomes the dominant follicle. And that's the one that grows the biggest. And that's the one that releases the egg that becomes the baby. So that you can see how special we are. That's how special God makes us. That out of the thousands and the millions of eggs, God has, chosen the egg that will form us. So you are special. That's something else I will just add onto it today, that you're special. Never think that you're not special enough. All right. So one of the eggs begins to grow. You can look at the ovarian cycle, the one in the I don't know if you can see this page. Yeah, the one in the second line up. So the eggs begins to grow, begins to mature, begins to grow, and once it gets to a particular size rather, it sends a signal to the brain and say, I'm the one who is going to be the dominant one. I want the rest of the follicles to die. So because as the I'll use egg, as the egg is getting bigger, as the egg sac is getting bigger, it's producing estrogen. So the estrogen is going up. Yeah. The estrogen is what makes us feel feminine. The estrogen is what makes us feel, like women. And it's the estrogen that makes the lining of the womb begin to get ready, to thicken it up like a nest. It begins to thicken up. It's thicken up and thickens up. Yeah. So once we get to a peak, the FSH then drops. So that is the follicular phase. That's the first half of our cycle. I don't hope we're not getting confused. I'm going to explain. The reason I'm explaining this now is so that you understand when we're talking about HRT, what we're trying to replace. So in the first half, to make it a summary, estrogen increases and FSH begins to decrease because it does not want to give you another it doesn't want to grow another follicle. You only want the one follicle. That's what we want, because as humans, we usually have just one baby or maximum two babies, naturally. So then we have, once we get to the high to once the FSH has dropped and we have the estrogen, the brain sends the second hormone called the luteinizing hormone, the LH. So this one then matures the egg, makes it ready to be popped out. Yeah. And then you have the LH surge. And after we have the LH surge, about 36 hours later, you have ovulation, which is releasing of the eggs. Once we've released the eggs, we then begin to produce progesterone. Progesterone is then the thing that makes the lining of the womb become very fluffy and ready for, and becomes thickened, ready for the implantation for the baby to come if you get pregnant. If you don't get pregnant, the progesterone level drops and then you have a period, and that is it. The reason I'm talking about all of this is that in our HRT, we have estrogen and we have progesterone. So usually estrogen is what we produce in the first half and progesterone is what we produce in the second half. Okay, so that is the menstrual cycle. So we're going to talk about the causes of menopause now, which is where we're going to. So menopause could be caused by internal factors or external factors. So when I talk about internal factors, I'm talking about what I've just explained. Our brain, our ovary has finished its work. It does not have any more eggs in it. So our hormones are fluctuating. We're not having that usual, cycle of hormone up and down that we have normally. And then secondly, we have the external factor. For some reason, we might need to have our ovaries removed. It might be due to an ovarian cyst. It might be to torsion when it's twisted on itself. It might be to cancer or anything, but or doctor said, or endometriosis. Doctor says we need to remove this because it's causing pain, or because it could lead to further, sicknesses, or which, like I said, it could be illnesses. So those are things that could cause the menopause. So it could be, like I said, natural. Embryonic means we are the ones that have caused it, maybe because of operation or things like that. And it could also be because we've had chemotherapy for different reasons, maybe for as a treatment for another cancer. Symptoms vary, and it depends different from people to people. In the past, they used to say, "Oh, the way they say black don't crack." That is so wrong. We've been stereotyped to be people that just keep quiet and suffer. So black people have menopausal symptoms as well. So people have, as I said initially, irregular menstrual cycles, heavy bleeding. As you get towards the menopause, you see the periods are every, like I said, I'm a gynecologist, and a lot of time people come to me and say, I don't know what's happening to my period. It's just going up and it's getting heavier. Or some people say, oh, it's getting lighter. It just doesn't come as often. So it's different. We are all different. What we need to do is that we need to make sure we get checked, make sure that there is nothing else that is causing the problem. Some have what we call the vasomotor, kind of symptoms. They have hot flushes or night sweats. You just lie down, and before you know it, you are just, it's all wet. Or you feel as if there's fire inside of you. One of my patients said, it's as if they're setting me on fire from inside. And that's all part of it. We have vaginal dryness, itching, and pain during intercourse. That makes it even difficult to want to have sex. At times you're like, oh, this is not for me. I'm just not having this, because we feel so dry. There's something we call genitourinary atrophy as well of menopause, because everything is dry without the estrogen. We have estrogen receptors, in the urethra, in the lower vagina, and when there is no estrogen, everything just dries out and becomes difficult, sore, and painful. And that's why we are prone to having frequent urinary tract infection. You're like, I had this UTI today. Why am I having it again? Why, it could just be because we are going through the menopause. And then some people say they feel like they can kill their partners or kill their children, because one minute they are happy, the second minute they are not happy. So we get lots of mood swings, then reduce libido. The estrogen is one of the organs in women that actually produce a bit of testosterone. So once it's gone, the testosterone level is low, and a lot of time we have reduced libido. Other times, because we have low mood, we also have reduced libido. And at this time is also when you have children, that children are leaving the house. So it's everything coming together can just make it very depressing and lower. And having sex is the last thing on the mind. Insomnia is when we are not able to sleep. We just wake up at night and we're like, why am I still awake? It's 3 a.m. Why am I still awake? It's all part of the process that we are having. Another common one is brain fog. Patients say, doctor, am I getting crazy? I don't know what's happening. I'm telling you something, and I just can't remember what I was saying. So we lose concentration, problems with memory. It's not dementia, it's just part of the menopause. And some have lots of palpitation, joint stiffness, aches, pains, fatigue, getting tired easily. So now, am I still in? I think I'm still in time. Okay. So now we talk about HRT itself and what HRT is. So remember that I told you about the hormones that are being produced by the ovary, the estrogen at the beginning and the progesterone at the end. So if you are having menopausal symptoms, you could actually start using HRT if you choose to. Before you get into the menopause. So it's called the perimenopause time or the menopause transition time. So if your doctor is going to give you a menopause, give you HRT, they're likely to give you estrogen and progesterone, right? If you have a womb, they will definitely give you a combination. If you've had an hysterectomy and your womb has been removed, they will give you the estrogen because it's actually the estrogen that we really need. That's going to help us to feel very much like a woman again, right? I'm going to use this analogy because I think it's very important that as women, we understand, or if you are a man, you understand what your partner is going through. That imagine that the womb, the uterus, is the lawn, your back garden, and you need to grow your back garden. You need to put sunshine, water, you need to put all that or rainfall, you need to put fertilizer and things that will make the your lawn to grow properly. You also then need to have a mower to mow it regularly, otherwise it becomes a bush. So that's why we need estrogen and progesterone. The estrogen will help makes the lining of the womb grow, but the progesterone would then mow it. And that's why we need estrogen and progesterone in our HRT. Otherwise, we could develop things like endometrial hyperplasia or endometrial cancer in the future. So please make sure, I know a lot of people don't like the effects of progesterone, they don't like the way it makes them feel, but I would advise that if you're going to use HRT, make sure you use estrogen and progesterone. Otherwise, you might end up having endometrial cancer, which is something you don't want. All right. So, like I said, you could either have a combined HRT or estrogen only HRT. If you're starting your HRT before you get to menopause, for those that joined late, menopause is when you have had 12 months of no period. So it's a retrospective diagnosis. Yeah. So if you're still having periods, your GP will give you sequential HRT, which means that you would use your HRT for the last 10 or 14 days of the cycle, so that it will be like, remember what I said, the rainfall is there, the sunshine, the fertilizer is growing the lining of the womb, then the progesterone is mowing it so that you do not develop endometrial pathology in the future. If you are starting HRT when you've already gone through the menopause, the GP is likely to prescribe a continuous HRT. That means a combination of the estrogen and the progesterone together. HRT can be taken in different tablet forms. We have them in tablets, we have them in skin patches, we have them as a gel that can be rubbed in the skin, and we also have them as implants. Some of the side effects are breast tenderness, just like when you're having the periods, because those are the same hormones that we're trying to replace. Headaches, nausea, vaginal bleeding, and the risks that are associated with HRT are usually the risk of blood clots, the risk of breast cancer, the risk of ovarian cancer, the risk of stroke, and of heart diseases. These are things that make people really, really worried about taking HRT. But we're going to put this in perspective in a little while so that we understand exactly how much of a risk that we have. So there's some contraindication to using HRT as well. And first thing is make sure you're not pregnant. It sounds very silly, but we need to make sure that we're not pregnant. If a woman is having abnormal vaginal bleeding, before we start giving HRT, we need to ensure that there's not cancer or endometrial hyperplasia or any pathology down below that is causing the abnormal vaginal bleeding. So most times the GP won't even start you on HRT until they send you to us so that you could have, a biopsy of the lining of the womb or a check to make sure that there is no cancer or anything abnormal. If you've had a recent blood clot or like a heart attack, you will not be given HRT. People that have active breast cancer or active endometrial cancers will not be given HRT. And if you have active liver disease as well, or abnormal functions, we won't give you that. Also, porphyria, if you have porphyria, you won't be given HRT. And this is me talking about putting things in perspective. So everybody's afraid, oh, I don't want to have HRT because of breast cancer risk. I don't want to have breast cancer, but this is a picture of what could cause HRT, breast cancer, beg your pardon. So if you look at this picture particularly, the top one, there are 23 cases of breast cancer that are diagnosed in the UK, assuming we're putting them into perspective now. So out of the 23 cases of breast cancer diagnosed in general population, if you're using HRT, maybe 4 extra people will have breast cancer. Yeah. If you're using estrogen only, for those who don't have a uterus, it actually helps because you can reduce the risk of HRT, of breast cancer. So people that have using estrogen only is actually protective, and they have for fewer breast cancers. People that have used the pill. So if you're using the pill and you don't want to use HRT, similar, isn't it? The risk of breast cancer is same for whether you're using the combined pill or whether you're using the HRT. So there's not much about it. But now this is where it gets interesting. People are saying, I don't want HRT, but they are taking alcohol. So if you're taking more than 14 units in a week, which is 2 units a day, which is, let me see now, a glass of wine is 9 units. So if you take more than, a bottle of wine, you must find about 9 units. If you take more than 1.5 bottle of wine a week, you actually are increasing your risk of breast cancer than if you took HRT. So that's why we have to manage the risk and understand what we're doing. If you're smoking as well, you're increasing your risk of breast cancer by 3. Yeah. And then if you have a BMI more than 3, you're actually increasing your risk of breast cancer even more. So there are 24 extra cases, if you have a high BMI. So those are things that we need to think about. And if you're very you do a lot of exercises, it's also protective against HRT. So that's all good. For us to understand that HRT, we say HRT is bad, or we're worried about HRT, but there are other things that actually causes more problems. I tell people that people die of stroke more than they die of cancer. People die of cardiac problems more than they die of cancer. But because of that little worry, we're worried. Oh, we don't want to have breast cancer. We don't want to have breast cancer. Then we don't want to use it. So this is something that's another slide that's talking about similar thing. It's talking about this is more like in the word part that you're 1.5 times at risk if you drink 2 or 3 units per day, of alcohol. And if you're obese, you have more increase as well. So these are things that could actually increase our risk to having breast cancer more than HRT itself. Right. Usually, when it comes to the risk of having cardiovascular problems, yeah, maybe things like stroke or things like heart attack and any heart disease, if we start using HRT before the age of 60, the effect is actually minimal. All right. If we use estrogen only HRT for those who do not have a uterus, it actually reduces the risk of heart disease or has no effect on heart diseases. Because all of these things, remember that we always have to think about all the other things, the lifestyle choices we make, the our family history, our genes, what we're exposed to at work. All of those things all come together as you. It's not that black and white that it's where. If you're using the combined HRT, it may have no effect on your risk of heart diseases, or it might slightly, but it does not have any increase. It doesn't decrease, but doesn't have any increase on your risk of heart disease. And then if you take the tablet, so this is where it gets interesting. I always tell people that it's better to use the transdermal, which is the one on the outside, or which is either the patch or the gel than the tablet, because the tablet actually has so much more side effects like blood clots and or strokes, or even affecting our hearts. Yeah, so the same thing I've just said here, that HRT tablets will increase the risk of having a blood clot. So if you have a strong family history, for example, would advise that you use transdermal, which is the one on the skin, which you just rub in, or a patch that you might have. And this is what I've just said, that there's no increase with patches or gels, right? So, and if you look at the total number as well, it's 2 people. So it's small risk, really, really small risk that we're talking about here. And I know that risk is dependent on people. Everybody's different. Some people don't want to take any risk at all, and some are happy to take a bit of risk. Next slide is talking about the lifestyle choices that we can make. So, for example, we know that we have hot flushes. We know that we have night sweats. Keep your room cool. Wear light clothing. Take cool showers. Use fan. Have cold drinks. Reduce stress level. Look at things that trigger you: spicy food, caffeine, smoking. Live healthy lifestyle, regular exercises, and lose weight. If you're able to. So there are things that would reduce our risk. Right. So now we're going to go to the things that are not like the typical HRT, and I've got them listed here. A lot of people actually do not have, like I said, sex drive or libido once they get to menopause, and they want to use menopause. They want to use testosterone. There's a lot of patients coming in wanting to use testosterone. Before we prescribe testosterone, we tend to advise patients to try other stuff, because testosterone is a male hormone and it has to be monitored. It's good for some patients. It works brilliantly. Their life is back. They're like, give me my life back. And for some people, it doesn't work at all. So what we tend to do is we do a blood test, make sure that the testosterone level is normal or low. If it's low, then we can supplement. And before we supplement, we also make sure that your estrogen level is optimized. So if you're using HRT already and you're having estrogen and progesterone, if your estrogen level is not high enough, we'll then ask that this be optimized. Maybe your GP gives you extra if you're not on the maximum. If you're on the maximum, we can change from gel to patch, or change the type we're giving you to just make sure that we get you maximized with your estrogen. Then we give you testosterone. Testosterone has a side effect that it could actually make you start growing hair. It could also make your voice become deep. And the bad thing about testosterone is, once it has hit your voice and deepened your voice, you can't reverse it. So that's why before you use testosterone, we have to make sure you don't just buy it off the counter or off the internet, like some people just buy things off the internet. Make sure it is being monitored, because the GP will do your blood test for 3 or 6 months to make sure that it's not getting high. And if it's too high, they will stop it before it has this effect. These effects are irreversible. Next, I'll talk about cognitive behavior therapy, particularly for people that have psychological effects like low mood or depression. So cognitive CBT is when we get psychotherapists, or psychologists actually help get people together and then talk things through. And it helps some people, but not everybody. We can use clonidine as well. It helps some people with basal motor, particularly people that maybe they've had cancer before and they can't have estrogen because their cancer has got estrogen receptors, meaning that once estrogen hits them, the body, and if there's any bit of the cancer around, they will start growing the cancer again. And so for some people, they don't want to take that risk at all. There are lots of herbal medicines, and I always tell people that I'm not a herbalist, so I can't tell you which herbal medicine works or not. But I know that herbal medicine works. We have things like black horse, we have things like red clover. We know we have all sorts of things that people talk about. Evening primrose, they're quite nice, but I think there's something called traditional. I wrote it down so I won't forget. Let me see if I can find it. I wrote it down somewhere. It's called traditional medical stamp. I don't know where I wrote it. I wrote it down somewhere. Stop. Yeah. It says traditional herbal registration number. That's it. So if you're going to buy any herbal medication, make sure you have the traditional herbal registration number. At least that way you know it's pure. Because unfortunately, from herbal medicines are not licensed like pharmaceuticals. Those that are licensed know that if they do anything wrong, their licenses can be taken off. But traditional medicines are not licensed. So just make sure you don't buy from just anybody, and make sure that it's got a bit of registration to just for your own to help you. We have homeopathy, acupuncture, osteopathy, chiropathy. Like I said, we know we have pains with joints, and at times something things like that could actually help to help us become better and stronger. Right. This is the list of some of the medication I spoke about. Um, we give SSRIs, which could be an antidepressant. It's not used for depression. It's usually for maybe just low mood, and also helps some people with their reduced libido and sexual response. The black wash, too much of it could lead to liver toxicity. We don't even use the kava in the UK at all. The evening primrose oil, some people say it's fine, some say it's not fine. It depends on who you ask. Juries out there. And then some of the things like red clover, soy products actually have a form of estrogen in them. So you don't want to be having too much estrogen. So that's why we need to have a balance. And I believe that we need much more research in all of these alternative treatments to be able to know which one is best for us. At this point, I think I'm going to stop and say thank you for listening. I'm impressed. I spent within time, so that's good. Yeah. I mean, there's something I want to drop in quickly before I say ask for questions. The reason is one of the things that estrogen does. Two things it does actually is that estrogen protects the heart. It's got some cardiac protective functions. It also protects the bone. So estrogen is useful for the bone. So that's why at times people want to have it, because it reduces the risk of having, osteoporosis and fracture. That's the advantage of HRT. So I'm not working for an HRT company, and I'm not saying yes, we all have to go to use HRT. Some of us can cope without HRT, and others can't. So this is just to remove the stigma and say there's nothing wrong with HRT. If you want to try it and see if it works. Well, at times, just understanding the physiology of a process makes you realize that, oh, I'm not mad. I'm not running mad. I'm not having dementia. I'm fine. I'm just going through a change. And most people will get better with time. Thank you very much for listening, and I'll be happy for any questions. Can I
In outflush, night sweats, and my period is no longer regular. So does it mean I'm premenopause as I've not had period free for 6 months. Also, are there any supplements I can use during this period of premenopause and also experiencing vaginal dryness? So what off-the-counter medication can I use at the moment using Replen MD
Yes.
moisturizer? Yes, so all of that is from that
All
person.
right. Thank you very much, Inka. Thank you. That shows you're really engaging. Yes, you're correct. You are menopause. You're not menopause yet. You need to have 12 months. And it can be very frustrating because you're thinking, yes, it's 3 months, it's 4 months, thinking that you're going to stop and then you don't stop and then you start again. But that's, like I said, I don't know what time you join. It's like a flicker of the bulb. When it's going off, it goes off and then it comes back and it goes off. And yes. So I would say, for when it comes to supplements, one thing I didn't mention actually, simple things like vitamin D, magnesium, vitamin C are very good. B, no, the B12. You can get the Well Woman. I don't work for Well Woman as well, so, but you can get the Well Woman version of Tesco's or Finsbury or any one of them that is for women in the right age range. They're full of all these supplements that could help. I'm personally not a supplement person. I think apart from vitamin D and vitamin C, I don't take supplements. I try to make sure I eat fruits, vegetables, and I have a very healthy food. I don't know how active you are. This is the time to redefine yourself. This is the time to go on walks, lovely weather. So go on walks in the evening after work and just take away the stress, take away the pressure, and that will help you cope. With regards to vaginal dryness. So the GP could actually give you, and thank you for mentioning that because I skipped that for some reason. I don't know why I didn't write it down. I have to add it to the slide. Is the vaginal estrogen. You can have vaginal estrogen. As part of my talk, I said about how we have estrogen receptors lower down there. And when the estrogen level goes down, we begin to have dryness. That's when we begin to have prolapse as well. So pelvic floor exercises are good. Get vaginal estrogen. Your GP will have to prescribe that for you, and you can use the estrogen therapy to help moisturize the place. Otherwise, apart from Replens, there are other nice moisturizers. We have one called Silk, SLYK, and there's one that was actually done by chemist. She is a pharmacist, and she was running mad and had to do something for herself. It's called the Yes product, so YES. I've had mixed reports from my patients. Some say, oh, saved their life. Some said it was a waste of their time. So this is when you begin to look for what works for you and use what works for you. So yes, the Replens, the Silk, and definitely see your GP to give you vaginal estrogen. Even if you don't want to use systemic, I mean, the one that goes to your body, you don't want to use that as your um, HRT, you can always use the vaginal estrogen. It's very, very limited risk.
It said many Black and Asian women reported that being not being believed or supported when they talk about menopause symptoms. Why do you think that is, and what can we do to change it?
Unfortunately, it's just shouting health inequalities. For those that don't know at the beginning, I started with, yes, we are human and we do feel pain. Yes, we are human, and they say black men don't crack or black women don't crack. But yes, we crack, we do crack. So I think it's just about being persistent. And then I think other things is that, which I was thinking actually that we don't have enough research
Yeah.
when it comes to these black women, that I was just thinking in my head. I've told one of my trainees that we have to do things, even like PCOS amongst black women. How is it different? Look, a lot of things we do is just for the Caucasians because they're the ones that do the study, apart from when they've used us for studies, but that's a story for another time. But more importantly, I think we have, thankfully, we have people of the global majority. We have people like us that are beginning to get into high places and hopefully be able to do those researches that will be beneficial for us all, because we do need to know what is wrong with us. We're different. We are so different, and we do need to be able to help ourselves to get to where we need to be, so that we can reduce this health inequality gap. So what I would advise you is this: go to your GP until your head. I'm sorry, GP, but this is what I feel. I would like to have HRT, or GP, I'd like to have this done. Your GPs would listen. They would listen. The more you go to them, the more they will listen to you. All right.
Thank you so much. Another question from the chat box is say lately we have had young people having perimenopausal or even menopausal symptoms, age 28, between age 28 and 44. What is the cause and what could be done? And that's from Demilola. Yeah.
Thank you very much, Davidola, for your question. It's difficult because there are different things that could cause it. Yes, we have people with what I call premature ovarian insufficiency or early, premature menopause. So if you're having that kind of symptoms, you are asked to go and see a GP, so they can start some blood tests. So to diagnose menopause, if you're more than 45, we do not need a blood test for menopause to be diagnosed. Once you have those symptoms, the GP can tell you that you're going to menopause. But if you're less than 45 or at least less than 40, definitely, and you're having those symptoms, one of the things you should ask your GP to check is your FSH. Because remember what I said at the beginning? I don't know if you remember when I was talking about the physiology. The brain sends FSH to the ovary and tells it to work. So as we get older, our FSH level is higher because the brain is sending more FSH. It's like flogging a dead ox. I say, come on, you can do it. Come on, you can do it. So our
Mm.
FSH levels are high when we are menopause. And that's one of the ways we can diagnose menopause. So if you've got pretty much if you've gotten the symptoms, one of the things the GP could do is take your FSH and they'll check it at least 8 weeks, 12 weeks apart to make sure it is high. If it's high on both accounts, then you're likely to be going to early menopause. If that's the case and you don't have children, tell them to refer you quickly to the facility you need because then you can have your egg stored. And
Mm.
then in future, when you're ready to have children, you can have children. Or you can, if you have a partner, you can actually have embryos created and then you can have your embryos stored for when you're ready to have children. That's fertility preservation. Other causes of of all these perimenopausal symptoms could actually not be menopause. So if it's not menopause, or it's also, for example, some people when they are breastfeeding, they're not ovulating, they're not releasing estrogen, they have vaginal dryness, they feel a bit menopausal because there is no estrogen. So those are can be because you're breastfeeding. It could be because of in that place of low estrogen. So I think most important thing I would say, the causes I'm not sure of. We actually having people that have early menopause. It could be genetic. So we
Yeah.
tend to ask anybody in the family with early menopause. It could run in family. It could be genetic. If the GP would do blood tests or send it to the hospital where they can do blood tests and check for things like Fatal X, Turner syndrome, or that kind of syndromes that could cause early menopause. So yes, and at times, I mean, one of my trainings is so particular that the things we expose ourselves to, the chemicals we expose ourselves to is affecting us. So let's try and
Yeah.
be as natural as possible to reduce all some of these things that we don't really know what the effect is having on our bodies. Yeah.
Brilliant. Another question coming in from here. How can we support women em emotionally and spiritually during this transition, especially those who are feeling isolated and ashamed?
Well, I think when things are being spoken out like we are doing now, there is no
Yes,
stigma in it. There
brilliant.
is no stigma in it. We all going to go through it. You may think you are 21 today, but before you wake up, I somebody sent me a WhatsApp message and showed me and said, I suddenly woke up and it's born in 1975. He said, I suddenly woke up and I'm 50. What happened? How did that happen? So that's what happens to all of us. So I think we need there are support groups around. There's the menopause matters. There's a lot of support groups around.
Yes,
Just need to Google it and we can find it. But there's none that is particularly for African, Asian, Caribbean people. Also for there's a lot of community of support group around. So just go in and join in and plug in. And when you know that it's not just you going through it, then it's helpful. I don't know if we're all Christians on here, but there's another twist I'm going to put to it. So because something happens does not mean it has to happen to you. It could happen to I would say about 50% of women have very this menopause. Some people go through menopause and they don't even have any feeling at all. So
hmm,
what you should do, which is what I do well with all the phase of my life, is before I get to the next phase of the life, I begin to pray and prophesy to that time. So um if you're young and you're thinking, my God, this is what's going to happen to me when I'm older, you can start saying, God, I thank you for my 50s, my 40s. It's going to be good. I will transition into
Amen.
menopause properly. There'll be no this. I will not have hot flushes. I'll be able to manage. You can transition into all of these things properly. So I'm telling you the science behind it. But like you said, the spiritual behind this is, and
Mhm.
and it's not because you don't have faith that you have. I don't want to put it that way as well, because at times as people are like, oh, you're not praying enough. That's why you're having it. You don't have enough faith. That's why you're having it. So I beg you, that's not what I'm saying. If you're going through it, know that God is with you. You can do all things through Christ who strengthens you. Even if it's having people that you go and you just go on walks together, or just encourage one another, talk about it, laugh about it, go on a girls, if you can afford it, go on a girls trip and just relax and enjoy the moment. It's part of transition, and most people it will pass. And one good thing about us as African though is that because of our body shapes, we have extra fat cells. Our fat cells give us extra estrogen. So at times it's a bit more comfortable for us than it is to our Caucasian Caucasian women. Yeah.
So you've gone into something the next question actually.
All
Are
right.
there differences in how menopause presents or is experienced across different ethnic groups?
It is different
Yeah,
amongst
you
different
said
ethnic
something.
groups. It is different. It is different. I think if the Japanese, oh, I'm not getting it right wrong now. I think among the Japanese women, I think it's actually they don't feel it that much. Like if I'm correct, don't quote me on that, but it is very different amongst people. And also, it could also be cultural. It could be that
Yes.
some people talk more than others talk. And if you don't say it, nobody knows you're going through it. So it could also be cultural because, like I said, when you ask somebody that, oh, what does the labor mean? I remember when luckily I'm a doctor, so I knew what labor meant. But some people go into labor say, I never knew what labor meant when I'm from Nigeria originally. I'm
Mhm.
Nigerian British. So when I trained in Nigeria as well, and people will come like, I never knew it was this difficult to get pregnant. My mom had to have a baby. Nobody told me. My aunties didn't tell me. My mom didn't tell me because we don't talk about these things, isn't it? So that could be why it's not reportable. Overall, from people that researches that we have, it's different across board. And some people it's just night sweat. Some people it's just palpitation, anxiety. So things that they don't have before just begin to show up. So yeah.
Thank you so much, Doctor. Another question in the chat from Damilola. I have someone age 49 plus pregnant twice, one alive, and she still wants to conceive, but she's already having menopausal symptoms. Can she take HRT?
It depends. I think if she wants to get pregnant, she should concentrate on getting pregnant because it's a bit what's the word I'm looking for? To try and get pregnant now
Mhm.
because she's got a basket full of not no longer full of eggs. She's getting to the bottom part of her eggs. And the good thing about being pregnant at this time is that they tend to have twins actually because the FSH level is so high.
Mhm.
And remember, it's FSH that recruits the eggs. It recruits even more. It can recruit on both left and right. So they tend to have, non-identical twins a bit more at this age group. So I would say it depends on what symptoms she's having. If she's having, like vaginal dryness, she could use vaginal estrogen. That won't affect her getting pregnant. But if she wants to get pregnant, her GP won't prescribe HRT for her as the
Okay.
estrogen tablets or transdermal or any of that for her to try and get pregnant. So she can try now to get pregnant, use other things to try and manage. She can try the maybe the clotidine if she can. It's just for blood pressure normally, but she could use that. She could try the evening primrose, all those little herbals, and see if it works for her. And if it doesn't, then at some point she needs to give herself a gauge and say, maybe when I'm 50, I will stop. Or when I'm 51, I will stop. And then she can then concentrate on the HRT.
Great. I've got two more questions. There's a lot of thank you, a lot of members saying thank you, but I've got two more questions. One is, what should we be asking GPs if we think we're in menopause, but we're not being taken seriously?
It depends on what you want out of it. If you're thinking you want HRT, because that's what most people want when they see
Mhm.
their GP, because other things you can change, like lifestyle, exercise, none of those you can change. But if you're thinking of you wanted HRT, if you're less than 45, ask your GP to give you to do a blood test for you. It's called F for father, S for sugar, H for house. So follicular stimulating hormone. That's usually it shows that you're perimenopausal. If you're more than 45, just tell your GP that you don't need blood tests. That's what it's the policy. You don't need blood tests once you're more than 45. Your GP, it's just the symptoms that come through, and your GP will be able to treat. But they won't, like, for example, you can't say I have reduced libido, I want testosterone. They won't give you testosterone. They will want to, especially if you're not using anything else, they want to maximize your estrogen first, because testosterone is a male hormone and it can make you muscularized, and you don't want to be muscularized because they are irreversible.
And Charles is asking, well done, doctor, for this beautiful lecture. Question, does irregular sex cause early menopause?
No, no, it doesn't.
Brilliant. And then any question?
Although irregular sex as we get older
Mhm.
can make the vaginal close up quicker. So if you don't use it, it just gets, especially if you're getting older, it just makes it more difficult and more painful.
So I'll just put up this last question. I know you mentioned about different alternative remedies, but just what natural or alternative remedies actually work and which ones are just myths? So if do you have anything to talk a little bit about the myths?
I always tell people that I'm not a herbalist. I'm not a doctor.
Yes.
But but I think it all depends on you as a person. You go to
Uh-huh.
one of those herbal shops, like Holland and what are they called? Holland and Bennett or something like that.
Hmm.
I don't know what they're called. You go to one of
Hmm.
those shops, they would actually sell you what you could try. And some of them, the ones that we use that we recommend are things like evening primrose, no,
Yeah.
sorry, red clover, black wash. These are things that we recommend, but a little bit, because we don't, there is no large study to see if they work or not. And honestly, for some people, anything, if I give you treble and that just suck on treble, it will work. Just that placebo effect at times will work for people. So for with the herbals, I'm not sorry. Thank you. Supervisor Holland and Barrett. Thank you.
Thanks very much, Doctor. I have one or two questions that have been sent to me here. One of them is that during this transition period, many people are affected
Mm.
who are connected with the woman,
Mm.
but he is specific about the husband, the leaders and colleagues at work, and the children. Some of them are likely to listen to this webinar later, or they're even present. Now, what should they expect? How can they cope? Or what is your suggestion or advice for them? Because it could be a very difficult time for them too.
Yeah. I would say I was very happy when I saw some mail here. I was really, really impressed because I think you need to go understand what's happening. And and most important thing is support. The Royal College of ONG are trying to push women's health into the national system. For example, in my hospital now, we have like a menopause support group where people actually have. I don't do yoga, but they do yoga. They do all sorts of things. They have talks, helping themselves, helping one another. So those support groups, if you're a manager at work, I would encourage all you to do support groups and understanding how you can support the women when they're going through this transition. For the husbands, it's very important. I'm sorry, I'm kind of and I'm not ashamed. I'm going to talk about myself. So sorry if I'm giving you too much information. I remember when I started going through the menopause, and I would just lie down, and my husband just look and say, what's happening? Did you wet the bed? How come the bed is wet? I have to now explain to my husband and explain that this is night sweat. I'm sweating, and thankfully, God has is less than it used to be. Sleep with very thin you know, nightgown, maybe cotton nightgown, or if you can't sleep, if you don't, or sleep with nothing as well at all, so that you don't sweat through the night. You understand? So the husbands will understand, should understand that. Also, for the husbands, when the wife is saying no to sex, it's not because she doesn't love you anymore. is because of things that are happening. So be gentle with your wives, be loving. I think this is where you need a bit more, more understanding. So I would say this is when you have to be more intentional when you're making love with your wife. This is when, if you want to use uh, uh, the gels, even the husband, to make it less traumatic for the wife. This is where you need to do more foreplay so that you can help the wife to get more secretion. So it's about that gentleness, that support, and also trying, and for the children to know that mommy loves you. She may feel like she wants to kill you today. She may raise her voice because because things are not going well. I use myself for example. I realized that with my daughter, I've got adult children. I realized that with my children, I could get short, I just realized that I'm just raising my voice, and I have to tell myself that my emotions will not rule over me. I'm God's child, and I've got the spirit of God, and so my body has to submit. So for us as well, I'm not using that as an excuse for I'm not using that as an excuse for murder. I'm just saying that we have to take responsibility as well by telling ourselves, talk therapy to ourselves and thank God I can do all things through Christ who strengthens me. I've got the mind of Christ. I am not angered. I'm not easily angered. The anger of man does not give glory to God. So those kind of things will help us to not just shout out. In fact, I told my husband, I said, you know what, sweetheart, I have relinquished my right to anger because I realized I was just getting angry so quick. I said, I'm relinquishing my right to anger. I'm putting it at the feet of the master. And those are things that help me. I'm being personal now because I think at times it's nice to say these things to help other people. Has that answered your question, sir? So it's more of support.
Yes.
It's just that support and understanding the process.
Yes, thanks very much. Just one more. I was actually going to ask, is there any link between menopause and other diseases, especially heart attack? But somewhere midway, you answered the question, but out of that question, I have another question.
Yeah.
You say it doesn't affect the risk of heart disease or stroke if it starts before age 60.
Yeah.
Can you say a bit more about that?
Okay, so the estrogen only. So like I said, we have estrogen only, and we have estrogen and progesterone. So if you use estrogen only HRT, it has no effect on the heart because estrogen itself is protective to the heart. If you realize that people that use no HRT at all, as they're getting older, they could easily have fractures because their bone density is less. There's no estrogen to help them with their bone density, and they could have heart problems as well because there is the estrogen protective effect of estrogen is gone. Right. So if you are less than 60 and you're taking your HRT, you're continuing with that protective effect of estrogen on the heart. But if people that suddenly starts HRT, because some people don't use HRT at all until they are much later. I'm like, you know what, I suffered enough, I don't want to use it at all. I think the studies just show that people then have things like stroke, things like heart attack, they have it more after 60. I would say, I think it's because we've gotten to a position where we no longer have that productive, we've had gaps of not having that productive, of not having that protection. That's what I'm looking for. And then we also know that it's the progesterone that leads to the blood clots that we are having. And so by the time you get to 60 and start using it, and even the combined one, then it has an increased effect on our heart, and then we can have heart diseases.
I'm just going to close with thanking you, Dr. Awi. On behalf of the Come Let Us Community Project and everyone who joined us tonight, I want to say thank you so much. And thank you everyone for joining today. And we will see you again next, the last Thursday of the month. Thank you.